Moderators. I'd invite our moderators to put their cameras on. So welcome everyone to the first of our PanAmerican Hemodynamic Collaborative webinar series in collaboration with the Neonatal Hemodynamics Research Center of 2022. I'm delighted everyone's here today, wherever you are, all over the world. Welcome. It blows me away to hear from one of our colleagues on the executive committee, Gani, that we have 1,700 registrants for today's event. And that certainly is very welcoming to my heart to know that there are so many people all over the world that are so excited about neonatal hemodynamics. So for those of you that are here, thank you. For those of you that will join after, I know many of you, because of time restrictions, are only going to link in when we have this on our YouTube webinar. So welcome. Some housekeeping first. Once you register for the first webinar, you should automatically receive the registration for all of the webinars in the current year, and our schedule for the webinars is already there. And finally, for questions and answers, please put them in the Q&A tab, not in the chat. It's going to be much easier for us from that perspective. So I'm delighted to introduce our two moderators who will take over the session from me. First, Dr. Audrey Hebert is a neonatologist in Quebec City. Audrey is the director of the Neonatal Hemodynamics and Targeted Neonatal Echo program, and has done some very innovative work on pulmonary vascular disease as her area of focus. And secondly, Dr. Amir Ashrafi, who is the clinical director of the Neonatal ECMO program at Children's Hospital of Orange County, also the program director of the Neonatal Cardiovascular Intensive Care and Hemodynamics Fellowship, which was the second official accredited fellowship in hemodynamics in the United States. Amir is also the founder and director of the Neonatal Heart Society. So Amir, Audrey, take it ahead.
Excellent. Welcome, everybody. Thank you so much, Patrick. Welcome, Audrey. It's a pleasure to have you all here. For those of you that have been to this program in the past, you know it's pretty outstanding, to say the least. For those of you that haven't been, and this is your first time, what we'll do is we'll typically find a giant in the field of neonatal hemodynamics, listen to their talk, their didactic, and usually we're pretty blown away by it. It's pretty awesome, and today will be no different. But that's just the first part of it. I don't know about you guys, but whenever I hear a really fantastic talk, it opens my mind, I get excited, but the hardest part is applicability. How do we take what we learned and bring it to the bedside? And so to do that, we also, in addition, are gonna have the who's who in the field of neonatal hemodynamics today to be on panelists, to comment, go through Q&As after this didactic. And let me first start by introducing our panelists today. We have three of them. The first one is Dr. Pia Windermark. She trained at Boston Children's Hospital and Lausanne University in Switzerland. She's a neonatologist and associate professor in the Department of Pediatrics at McGill University, and she's a true physician scientist. She's part of the Child Health and Human Development Program at the Center for Translational Biology at McGill University, and she is the founder of the Neo Brain Lab, which is devoted to understanding the causes and consequences of brain damage in sick babies. Our second panelist, I'm proud to say, he's a mentor, he's a colleague, he's a friend, Dr. Wyman Lai, an assistant division chief of cardiology at Children's Hospital of Orange County. He's also the co-medical director of the Heart Institute. Nationally, he served on the American Society of Echocardiography board of directors, and he currently sits on the National Board of Echocardiography Board of Directors. I also want to give a shout out and a plug. He just published his third textbook, Echocardiography in Pediatrics and Neonates. For the first time ever, there's a chapter here on targeted neonatal echo, and I think there's more content on here on hemodynamics than there has been in years past, so please take a look. And our third panelist, Dr. Willem de Bood. He's currently a professor of neonatology at Reboud University Medical Center. This is also where he received his PhD with high honors in advanced techniques to investigate and monitor blood circulation in newborns. On a national level, he's the former chairman and co-founder of the Dutch Neonatal Hemodynamics Network and an active board member of the Netherlands Neonatology Network, N3 as it's called. Internationally, he's a huge player in the European Society for Pediatric Research, multiple boards, multiple sections. In other words, he's a big deal. But really, the reason we're all here is for somebody who, in my eyes, is a really big deal. This is one of the emerging giants in the field of neonatology. In fact, you could argue that she is the giant in the field of hemodynamics. She is that unbelievable balance of brilliance, just abject passion, and balance it all out with humility. In fact, the first time I met Dr. Regan Giesinger, we were at PAS in Toronto, and we were at a restaurant, and she was talking about something that went way over my head. And then she's kind of, but you already know that, don't you? And so, of course, I nodded my head going, oh, yeah, of course, knowing nothing what she was talking about. Go and look it up and realize that everything she said is right. So it's a real honor to hear her speak today. Quick background, she completed her NICU fellowship with the Royal College of Physicians and Surgeons in Ottawa, Canada. She completed a fourth-year hemodynamics fellowship with Dr. McNamara in Toronto, and she currently serves as a clinical associate professor of pediatrics in the Division of Neonatology at the University of Iowa, where she is the director of the Neonatal Hemodynamics Clinical Training Program. She serves on the executive committee of the Neonatal Hemodynamics Special Interest Group for ACE, and her interests, specifically with regards to research, is on the hemodynamics of critically ill neonates and the relationship between cardiovascular function and neurologic injury, in particular among neonates with hypoxic ischemic injury. And her lecture today will be RV function and neonatal outcomes in HIE. So with that, I welcome Dr. Regan Giesinger.
Thank you very much for that introduction. I'm going to just show my slides and I'm going to try and live up to it. All right, just to confirm, you can see my slides, correct?
Yes, we can.
Perfect. All right, so again, thank you very much for the introduction and for inviting me to speak to this group. As mentioned, I'm going to talk about the association between right ventricular function and neurological outcomes in patients with HIE. First off, I have nothing to disclose. Secondly, just so that we're all starting from the same page, we all know this, but just to be clear, HIE is the terminology that we use to describe the brain injury, which results when fetal compensatory mechanisms to impaired cerebral blood flow fail. This leads to cellular energy failure, excitatory neurotransmitter release, and the release of other things like reactive oxygen and nitrogen species, and changes in electrolyte regulation. Together, all of these pathways stimulate the production of inflammatory mediators, which create a secondary phase of injury, and in that phase, cellular apoptosis occurs. Therapeutic hypothermia is one of the best studied interventions in the neonatal literature. We know that between 1998 and 2010, 7 trials randomized over 1,200 neonates with moderate to severe HIE to moderate therapeutic hypothermia or normothermia. And the composite of death or major disability favored therapeutic hypothermia with a number needed to treat of 11 for mortality and 8 for improved burden of neurodevelopmental impairment in survivors. So this is pretty good stuff. The mechanism that we have is probably multifactorial and complex, and there is still a lot of debate in the literature. The reduction in brain metabolism, though, which leads to lower oxygen extraction and utilization, and the modulation of cerebral blood flow with a reduction in edema and inflammation are among the most common mechanisms that we talk about. But still, despite this excellent intervention and optimization of the application of this intervention, we still have about 40% of babies with hypoxic ischemic encephalopathy who either die or are left with neurocognitive sequelae in 2022. So just to reiterate, I previously mentioned that there are 2 primary mechanisms of brain injury for these patients. One of those, and the one where therapeutic hypothermia is thought to play the major role, is in the prevention of secondary energy failure. There are many other adjuvant therapies that are under investigation for for use concurrent with therapeutic hypothermia in order to try and improve some of this residual burden of impairment in these patients. But one of the things we often don't consider is that hypoxia ischemia is often not a single time point event. And we've all had these babies where they are delivered and then they have multi-organ dysfunction, including hypotension, hypoxic respiratory failure, and we work very hard for hours to stabilize them. And that is an area where there may actually be ongoing injury and other cells moving into the latent phase. Pre-cooling studies have demonstrated that the pattern of blood flow to the brain in several major arteries is actually different in babies who do well versus babies who have adverse outcome. And either low resistive index due to high diastolic flow or high resistive index due to absent diastolic flow are more prevalent among patients with more severe injury. The other thing that we know is that the pattern of flow over the course of the first 72 hours to the middle cerebral artery as compared to somatic arteries, in this case, the celiac artery, is different. The middle cerebral artery has an escalating volume of flow, as you can see in the black bars, as compared to the white and hashed bars, which are the less severely injured patients, which doesn't actually occur in the celiac artery that has similar flow all across. But to understand the mechanism, we actually have to have simultaneous evaluation of systemic hemodynamics and cerebral hemodynamics. And none of the three studies that I've just quoted have any data on cardiac output or heart function presented. One of the speculations in the literature is that hyperperfusion may actually be part of the problem. This small cohort study published in 2014 demonstrated that patients with abnormal brain MRI after the completion of cooling had about 70% of their cardiac output directed towards the preductal circulation as compared to 50% amongst patients with a normal brain MRI. And this finding, in combination with the cerebral Doppler data I just presented, suggests that hyperperfusion may actually be a potential contributor to adverse outcomes in these babies. One of the other ways that we can look at this is by using NIRS, which is a non-invasive method of measuring regional tissue oxygenation, which I think most of us are probably familiar with. It primarily reflects the venous compartment and is therefore a measure of oxygen extraction by the organ. And just to remind everybody, high regional tissue oxygen saturation reflects low extraction, which may be seen either in the setting of high cerebral blood flow or low needs by the organ. Multiple studies looking at the association between high regional tissue oxygen extraction and outcomes in babies with HIE have been studied. And in fact, a large systematic review of approximately 50 studies was recently published and supports the fact that high RSO2 is a prognostic marker for poor outcome. The bar graph on the right is a comparator of a cohort of patients monitored with cerebral NIRS throughout therapeutic hypothermia. And they demonstrate that not only is high value for RSO2 prognostically poor, but also low variability in RSO2 is also associated with abnormal outcome. So if cerebral blood flow is different, perhaps the cardiovascular system actually holds a key to modulating disease. We know that cardiovascular disease is common in these patients. We also have very little literature supporting one therapeutic approach over another. And this suggests that this is an opportunity that's rife for study because it's an area where we're all doing something different and we're all getting different outcomes as a result of that. So if we accept the premise that cerebral blood flow and oxygenation are modifiable contributors to disease, then it becomes essential to understand the factors that modulate cerebral hemodynamics. And the initial insult, hypothermia, and rewarming all contribute to changes in cardiac output, changes in loading conditions, and both pulmonary and systemic vascular tone. And as you can see from this diagram, this interrelationship is potentially very complex. And all of this may contribute to either ischemia or reperfusion injury. We also know that the fetal adaptation to hypoxia ischemia potentially disadvantages the newborn in adapting to postnatal life. And just to kind of give people a refresher of what that means. So in fetal life, the baby adapts to a lack of placental blood flow by first centralizing blood flow to the brain, the heart, and the adrenals, so known as the diving reflex. A catecholamine surge vasoconstricts everything else, including the pulmonary vascular bed, and the low amount of pulmonary blood flow that normally goes to the lungs in utero is reduced even further, such that that blood can be diverted to the coronaries and preductally to the brain. And so when this fetus is subsequently delivered, the newborn has higher than normal pulmonary vascular tone from the very beginning. And we know that temperature alone, so the act of cooling the patient postnatally is also an important modulator of pulmonary vascular tone. This is a term baby who had a hemodynamics consult prior to cooling because the baby had severe metabolic and lactic acidosis and had an oxygen requirement of about 40% with a clear chest X-ray. So the clinical team was concerned about pulmonary hypertension and whether or not the baby would tolerate cooling. So on our initial evaluation, this baby had near systemic pulmonary artery pressure. And for those who are not familiar with this view on echo, this is kind of a modified ductal cut. The picture on the left was taken at close to normothermia. And the red jet there, which is indicated by the white arrow, is a PDA with almost all left to right flow, as indicated by the color moving towards the probe. We then proceeded to cool the patient, and you can see by the EPIC screen grab on the bottom that the FiO2 throughout the cooling process went from 40 to 50 to 75 to 100% by the time she reached target temperature. And this is the same view as on the right picture as you see on the left, and that ductus is almost all blue now, suggesting that it's almost all right to left. And this is because cooling increases your pulmonary vascular resistance by 1 to 2% for every degree of temperature. We also know that clinical research in this physiology is actually pretty challenging. And a lot of that is because the tools that we are using are too simple to be able to really firmly identify differences in postnatal perfusion from differences of the original insult. And none of these markers can help you distinguish that spaghetti of a diagram that I showed you before of the potential contributors to injury. In fact, we can't even agree in general on what abnormal blood pressure is in this patient population. So this is a survey that we conducted about 2 years ago now of 71 academic centers in North America. And we actually identified that there were 17 completely different definitions of hypotension that were being used in clinical practice to guide intervention with cardiovascular agents. And if we can't even agree on what is a normal blood pressure, it's really hard to understand how we could all be speaking the same language to conduct meaningful literature in this population. The other thing is that many of our markers, lactate, metabolic acidosis, are too difficult to interpret because they're more likely to predict the severity of the insult. On the left is an ROC suggesting that lactate and base deficit are more likely to predict the severity of insult than ongoing cardiovascular insufficiency. And the right shows you a complete lack of relationship between cardiac output and decline in lactate. Also important is that many of our end organ markers are unreliable. Acute kidney injury is very common in this patient population and can be quite severe. And in a very interesting adult study where they cooled patients who had normal renal function for a completely unrelated reason, they found a reduction in urine output by 5 mils per hour just based on temperature alone per degree in temperature. So suggesting that even cooling itself messes with our ability to use urine output. One of the things I just want to highlight before going any further is that echocardiography is really important in this patient population. And this is an example of one of the reasons why. This is a supposedly asymptomatic HIE patient who had a usual HIE type of course with poor APGARs. who had relatively normal heart rate, blood pressure, was in room air, and had a pretty normal looking chest x-ray. And because we screen at University of Iowa, we did an echo on this patient and actually found that this baby had an ejection fraction of 28% with a left ventricular output 1/3 of what it should be, and some of the lowest strains that have been seen in the modern world. And this is an atypical finding for HIE, but should remind people that it's not always a perinatal event that causes the patient to have encephalopathy. In this case, the baby had, you can see on the left image here, bopping by the aortic valve, and you can see on the right image here, completely occluded left coronary artery. So this is probably the reason why this patient presented with encephalopathy in the first place. So speaking about echocardiography in general, this is oftentimes something that's lacking as a systematic approach, particularly in the US. From this same survey where we asked about hypotension, we identified that about 41% of centers don't routinely do an echo, even if the patient is requiring vasoactive support, and that cardiac output and quantitative assessment of RV function are actually very uncommonly reported in the majority of centers, while ejection fraction is relatively common. And I'll show you in a couple of minutes why this is important. So again, why echocardiography? Echo identifies cardiac dysfunction, for sure. This has been shown in multiple studies using conventional measures on the left, or using more sophisticated measures such as longitudinal strain on the right, to show that cardiac function is lower in babies with HIE than in healthy term controls. But there hasn't been any association historically between LV dysfunction and neurological outcomes. So this brings me to our work. This was an index case when I was a brunette. That occurred on a Saturday morning, of course, that I will absolutely never forget because this baby scared me to death. This is a term infant who had thick meconium, delivered by C-section, typical story, poor APGARs, poor cord gases. And I got asked to see her as a very early neonatal hemodynamics fellow because of isolated systolic hypotension. And when I put the probe on the baby's chest, I thought that I had accidentally found a baby with hypoplastic left heart, because this baby's right ventricle was so big and so dysfunctional. And stemming from this got us all to thinking about the fact that maybe there was something intrinsically different about the right ventricle that made it more vulnerable to injury in this patient population. So after doing a whole bunch of research, what I identified that many of you may already know is that the right ventricle plays a dominant role in transition. And as a result of that, it has higher metabolism and a higher blood supply than it has at any other phase in development, and also than the left ventricle. Also, the conformation such that it's wrapped around the outside of the LV makes it intrinsically vulnerable, because that shape means that it's more vulnerable to wall stress. Higher afterload means higher wall stress, means more dysfunction in response to changes in loading conditions than the LV. And it also has a more vulnerable coronary circulation. And that's primarily because these patients have high central venous pressure with potentially low aortic root pressure because of hypotension and low cardiac output. And flow to the RV through the coronary arteries is dependent on that pressure gradient between the aortic root and the central venous pressure. So if that becomes low, then the RV may become ischemic because of low flow coming through there. And why had this not been noticed before? I think part of it is because this is a relatively uncommon patient population in one's practice, and we don't see a lot of these babies. But I think a lot of it also is because subjective assessment of the RV is actually quite limited in terms of its reliability and in terms of its validity, particularly for mild disease. And most, as I mentioned before, practices present only qualitative assessment, dilated, dysfunctional qualitatively. And so we didn't really have tools to be able to identify this until we started looking with normative data. So what did we do to interrogate this? We conducted a prospective observational study at 2 sites. We recruited neonates who were undergoing therapeutic hypothermia and met criteria for that at that site. And we looked specifically at 3 aims. The first is to evaluate the change in RV performance over time, hadn't been done. The second was to interrogate the relationship between RV dysfunction and death, abnormal brain MRI, or a short-term outcome, and a long-term outcome, which was abnormal neurodevelopment at 18 months. And then finally, we wanted to look at whether this abnormal cerebral hemodynamics that had been identified in the literature was related primarily to a supply or a demand problem. To show you our methodology, the clinical decision-making to initiate therapeutic hypothermia was all done by the team. Babies underwent standard monitoring throughout that period and rewarming. They all underwent a brain MRI at 96 to 120 hours and standardized neurologic exams throughout that, including a developmental assessment at 18 months. And the echocardiography was performed blindly at 24 hours. At 72 hours or just before rewarming, and then after rewarming. This is an example of our protocol. I don't need to go through all the details of this, but just to show you that we evaluated a lot of things. But in particular, we focused on RV assessment, including TAPSE, RV fractional area change, and RV peak longitudinal strain. And all of these are different ways of measuring RV systolic function. What we found was that the RV measurements, including most importantly, because I'm going to talk about them in a little bit more detail, TAPSE and RV fractional area change, were lowest at 24 hours and normalized by 96 hours. Some of the LV measures also increased over time, but the lowest values at 24 hours were still in the normal range for a patient at that age. And from this, we hypothesized that because the RV measures were substantially less than 2 standard deviations below the mean in the adverse outcome group and were 1 standard deviation below the mean in the normal outcome group, that the RV was the primary site of dysfunction and that the LV measures were abnormal, either due to a more minor degree of injury or ventricular-ventricular interaction in the setting of shared muscle fibers. For our second aim, we used the 24-hour echo, which was the most pathological, and did an ROC analysis to determine the sensitivity and specificity cutoffs that identified abnormal neurodevelopment or abnormal outcome for both TAPSE and RV fractional area change. And what we found was that both measurements, so TAPSE, which I've said a number of times but not defined for you, is the tricuspid annulus plane systolic excursion, so how far the tricuspid valve is displaced from the apex in contractility. It's a measure of longitudinal function. And RV fractional area change, which is sort of a surrogate of RV ejection fraction. Both of those measurements had sensitivity and specificity of around 80% and excellent discrimination on ROC analysis. And when you compare these key measurements between the normal and adverse outcome groups on the right, there's a clear difference in the measures of RV, but not LV function, but in the adverse compared to the normal group. And there was also a clear difference in regional tissue oxygen saturation of the brain between the adverse and the normal group. And all of these findings were independent of the severity of encephalopathy at presentation and early acute illness severity. We went on to look at the same markers, particularly TAPSE, because it was the one that had the best discrimination on the outcome of adverse neurodevelopmental outcome among survivors. And we defined this as a composite of cerebral palsy diagnosis, any Bailey 3 2 standard deviations below the mean, or severe neurosensory impairment. And what we found was that TAPSE had excellent discrimination with an area under the curve of 0.9 for this outcome. And when we went on to make a predicted probabilities curve, it suggested that if you still have a TAPSE of less than 4 at 24 hours of age, your likelihood of adverse developmental outcome was very high. Our third aim, we were looking at a comparison of cerebral and systemic hemodynamics to interrogate that relationship that we had seen in the literature. And what we found was that there was a higher regional tissue oxygen saturation concurrent with a lower left ventricular output in the adverse outcome group. And this suggests that the etiology of low tissue oxygen extraction is not actually an excessive flow or luxury perfusion, as had been speculated, but more reflective of organ utilization. To interrogate this further, we performed linear regression between both middle cerebral artery resistive index and left ventricular output with cerebral tissue oxygen extraction. On the left, you can see that the ability of MCA resistive index, which is a marker of perfusion pressure, to predict cerebral RSO2 is very poor. And on the right, not only is the ability of the LVO to predict cerebral tissue oxygen extraction poor, but it actually goes in an inverse direction, agreeing with the data presented on our previous slide. And together, this again reiterates the fact that this is likely a function of oxygen extraction rather than blood flow. So then the important question arises, does therapeutic hypothermia actually itself modify RV function? We know that there's an interrelationship between afterload and contractility, both of the right and the left ventricle. And so it's important to determine whether that increase in PVR actually is a primary determinant of RV performance. So to evaluate this, we took a cohort of 10 babies who had TN echo before and 1 hour after achieving target temperature. And we looked at markers of pulmonary artery pressure, pulmonary vascular resistance, and RV function and flow. And what we found was that in keeping with what we know from animal data and other data, we found that measures of pulmonary vascular resistance, including systolic eccentricity index or the degree of roundness of the left ventricle, pulmonary vascular resistive index in the presence of notching up to the PA Doppler were higher following therapeutic hypothermia. Similarly, in keeping with the literature, the outputs were lower. But these changes were not translated into changes in RV systolic function, suggesting that we could continue to look at this population without paying as much attention to the independent impact of cooling in this small cohort. So then we go on, we've talked about the association between these two things. And it's important to remember that so far, all we've identified is an association and not, and the next step is to look at whether we actually can modify cardiac function and that is associated with a modification of outcome. And that has not been shown. However, there are some suggestions that we can actually make things worse. So dopamine, we know, is a first line for hypotension in almost every disease, in almost every clinical practice across neonatology. And this has been shown in a couple of different surveys. We know that dopamine increases blood pressure in asphyxiated newborns. That's been shown. But one study that came out in 2020 actually demonstrated that treatment with dopamine was associated with an increased risk of the composite of death or abnormal MRI. To say that that's definitive is not, but it does raise the question whether our use of dopamine in these patients is justified and whether we should be thinking about how we're modifying cardiovascular function in these babies. Here's another study that has been submitted for publication. This is a retrospective cohort of 176 term infants from 2 centers. Center A featured a permissive approach to hypotension focused on the use of systolic and diastolic blood pressures and with echo-guided therapy wherever possible. Whereas Center B featured a more aggressive approach in which mean blood pressure less than gestational age was always treated with a vasopressor-focused strategy, and echocardiography was performed relatively infrequently. And what was shown is that nearly half of the patients in Center A were untreated versus only 3% in Center B, despite similar lowest recorded blood pressures. And in addition, hypertension was more frequent in Center B. The outcomes of this study, so although the rates of death or abnormal MRI were similar, the pattern of brain injury, interestingly, was somewhat different. despite less hypotension, center B patients were more likely to have basal ganglia injury. And this may suggest a more sustained or severe exposure to injury. In contrast, the patients in the less aggressive inotrope focus center were more likely to have milder phenotypes. And they had a more than 3-fold increase in focal and multifocal lesions and a 4-fold increase in watershed injury. Again, this is not definitive, but just raises the question that maybe cardiovascular modification can influence how brain injury occurs. We also know that there can be a lot of heart dysfunction despite normal blood pressure. So this is a cohort of patients in which inotrope treated babies were compared to control babies who had no inotrope treatment. And the predominant approach here was dobutamine or low-dose epinephrine in about equal proportions for treatment of hypotension. And what you can see is that at 24 hours, the systolic blood pressure, the mean blood pressure, and the diastolic blood pressure were basically all the same in the inotrope treated versus the control babies, because clinically we improved their blood pressure by treating it. But still, when you compare the echo, there is quite a degree of dysfunction present in both groups, with more severe dysfunction present in the inotrope treated group, suggesting that the burden of cardiovascular dysfunction that we don't see unless we look for it using echo is fairly significant, even in patients where we're doing the clinical best and making the blood pressure better. You can also see that there was a substantial degree of derangement in regional hemodynamics to the brain in both groups, with it being worse in the inotrope treated groups also. So another kind of cautionary tale, the medications that we use have a substantial impact on the kind of under the cover cardiovascular performance of these patients. And that's been shown in animal models specific to term babies with asphyxia. And in this study, they showed that a combination of high-dose dopamine, high-dose dopamine on its own, and or a combination of dopamine plus epinephrine, both increased the pulmonary artery to mean arterial pressure ratio fairly substantially, suggesting that these medications are under the covers, making that pulmonary vasoconstriction that we know these babies are prone to, both on the basis of that adaptive response that I mentioned and on the basis of being cooled, may make that actually worse. And we also know that the neonatal myocardium, particularly the right ventricle, adapts quite poorly to afterload. And so patients with a high risk of pre-existing RV dysfunction, who then are subjected to elevation in afterload on the basis of things that we're doing to try and make them better, may actually exacerbate RV dysfunction and may precipitate a substantial clinical decompensation. And we see this in babies who are sent to us, and we had one referred to us yesterday as an ECMO referral, who are on a lot of vasoconstricting medications with a failing RV. And just stripping away some of those pulmonary vasoconstrictors can make a substantial difference. So alternative therapies that we have, there are many of them. And all of these things are things that we use in our clinical practice. The problem with the patient population of HIE with cooling is that even though we have a lot of biologically logical options, we don't really have any specific data or very limited specific data to the HIE and therapeutic hypothermia population. And this is important for a reason I'll show you in a moment. So milrinone is a perfect example of this. Milrinone is a drug that has good properties that are biologically logical for these patients. It has literature to show that it's effective in reducing oxygenation index and oxygen requirement. It's associated with higher urine output, better pH, reduction in INO requirement. There's documented data in neonates suggesting improvement in heart function in a variety of patient populations. So what about patients undergoing therapeutic hypothermia with HIE? This medication seems like it should be a slam dunk. This is a cohort of babies who had acute pulmonary hypertension with refractory oxygenation failure. So that was defined by the study as oxygenation failure with pulmonary hypertension, with nitric oxide at 20 parts per million, and a requirement for oxygen of still 60% oxygen. The patients in purple were a set of milrinone controls. So these are patients with refractory oxygenation failure who were given milrinone as an adjuvant therapy. And you can see that their blood pressure stays pretty stable throughout, and their inotrope score actually declines a little bit after the milrinone, which makes sense. The green patients in the background are a cohort of HIE patients who had refractory oxygenation failure but were not treated with milrinone. And then the red patients were patients who had both of these therapies. So they were HIE patients who were cooled and who also received milrinone. And you can see that there is an early drop in both systolic and more significantly in diastolic blood pressure, which kind of gradually recovers over the course of 24 hours at a cost of an astronomical increase in the requirement for vasopressor and inotrope therapy. And if we think back to the proposed mechanism of ischemia reperfusion injury as a potential contributor to the burden of brain injury in this patient population, this is not a good thing to drop their blood pressure substantially and then spend 24 hours trying to jack up their drugs to catch back up again. And this makes sense when you think about the biology of milrinone. Milrinone is an active drug which is cleared almost completely with little metabolism through the kidney. And so patients who are cooled with acute kidney injury are not going to clear this, and it oftentimes sits around creating systemic hypotension. So here's just some take-home points for you. So cardiovascular health is an important opportunity to study and a potential opportunity to improve outcomes in these patients, but we really have to be careful that we're doing comprehensive monitoring, and we need to make sure that we're all speaking the same language about how we define things. The RV is particularly vulnerable, and we really should be doing objective measurements of it and comparing that to normative data in order to not only do better science, but also better clinical care. And we need to understand this disease better and how everything interacts and how the pharmacotherapy works. And we really also need to be careful of extrapolating from other populations, because this is a very different physiology with very different metabolism. And with that, I'd just like to close and thank the members of the Iowa Neonatal Hemodynamics Lab, all of whom have performed many echoes and listened to many speculations on this topic, and also to all our collaborators around the world. Thank you very much.
All right, thank you very much, Dr. Giesinger. You definitely lived up to that introduction. It was a very interesting talk. And if you, the participants, have any questions, please write them in the Q&A tab, and we'll make sure to convey them to our speaker and panels. So I'm going to start actually with one question for you, Dr. Giesinger. You did talk about merits of screening during your talk, and just wondering from your experience, clinical experience, and all the research you've done, would you suggest screening all HIE patients, or just ones with signs of maybe hypoxemic respiratory failure? Do you screen all of them at your program? So just want to hear your take on this.
Yeah, so I showed a couple of examples, but there are definitely patients who have subclinical both pulmonary hypertension, which they have good VQ matching, so they're not in a lot of oxygen at the time, but they have high pulmonary artery pressure. And patients who have subclinical heart dysfunction, that if you look for them, you can find them. I don't have science to say that it's wrong to not treat those babies until they decompensate, but my gut reaction is that dramatic changes in brain perfusion and brain oxygenation is not a good thing for these patients. And so anticipatory management seems logically to me like a good thing. We screen everybody except the occasional patient who may have a very weak diagnosis, who is on room air without a ventilator, and is being cooled kind of for mild HIE. So everybody who is moderate plus and absolutely everybody who's ventilated gets screened. And we find a lot of subclinical disease that then we treat gently and monitor the baby more closely.
Audrey, you're muted.
Thank you. If the panel wants to turn on their camera so that we can have a discussion. And you did mention other therapies that are being used, and there's one question about the use of vasopressin in this population. Do you have any experience using it? You did mention it in your presentation. And have you seen any difference in outcome with these patients?
That for me?
Yes.
Yeah, okay. So we do use vasopressin in these patients. The vasopressin doesn't have evidence per se in babies with HIE undergoing therapeutic hypothermia, but it's biologically logical because it's a good systemic vasoconstrictor that has potential for being a pulmonary vasodilator. It has no impact on the heart specifically, but for making sure that coronary perfusion pressure is adequate such that the RV can be perfused well, vasopressin is a very good agent for that. It's not going to increase your heart rate, and it's not going to increase your pulmonary vascular tone or your pulmonary pressure. So as systemic vasoconstrictors go, it's one of the better ones. But just want to stress that the primary approach for patients who don't have specifically low blood pressure, we typically use an inotrope focused approach for supporting heart function, as opposed to a vasopressor approach to drive up blood pressure.
Great, thank you. And following with Dr. maybe Wintermark, who's done a lot of research actually on other therapies being used on those patients. Do you have any, I know you've published actually a lot using sildenafil. Do you care to talk a little bit about other therapies that could be used in those patients, especially when talking about the hyper and hypoperfusion of the brain?
Yeah, so we are running the trial for sildenafil. Is mostly to try to repair the brain, but obviously we are looking at the cardiac effect. We have not yet the result. I will go with Regan that, you know, I think it's very important to monitor what you're doing, because we have watched a lot our population, and, you know, before there were people doing functional echo and people were putting all this inotrope. And I'm truly convinced, like Regan, that it can have side effect during these first 4 days of life while they are on cooling. So everything that is done to this baby during these first 4 days of life is very important and should be carefully monitored. So if you have all the resources to do it well and, you know, adjust the inotrope well, I think it's really good. But if you do it without looking exactly what you're doing, you can have much side effect. I will add that we measure directly the cerebral blood flow in the brain by MRI, so not by ultrasound. And we find that it correlates somewhat with the NIRS. So I think there is a problem of extraction, but there is still too much perfusion going in the brain of this baby, and, you know, a lack of autoregulation in some of them, which then make this drug potentially dangerous when you use them.
That's excuse me, that's actually really interesting. This brings up 4 or 5 questions on my own mind. But before I do that, I know that Dr. McNamara had a question specifically for Regan. Dr. McNamara, do you want to jump in real quick?
Regan, can you just, I want to make a comment, and maybe you can expand on that, because it actually fits with what Pia just said. Going back to the screening, is it important to know at baseline that there is bad RV function and your cardiac output is low? Because you put the babies on a lot of drugs to make their blood pressure better, when they're rewarmed, we know that their cardiac output is going to potentially double. So for that reason alone, is that information important from the purpose of screening, that we can then be very careful about how we manage the cardiovascular system during the rewarming phase?
Yeah, I think as a point of kind of, again, logic, it's really important that we think about that period of time as a period of vulnerability. And we do a lot to ensure that the babies are stable during the cooling period. And then we dramatically change the ambient conditions by rewarming them in the course of 6 to 8 hours. Knowing where you're starting from may help you know how to strip things away as you make those changes. And if you're in a situation where you're on a bunch of drugs and you've stabilized the cardiovascular system for a cooled patient, and then you're rewarming them and you don't realize that those medications can come away, you run a risk of causing reperfusion injury and reperfusion seizures and bleeding and all of those consequences also.
And kind of following on that, maybe a question for Dr. Duboud, but what are other modalities that we can have at bedside? We talked about NIRS during the presentation. I know you've published a lot about other hemodynamic monitoring. What are the things that we can do at bedside for these patients and make sure that we don't harm the patient more than more with our drugs or anything else?
Well, thank you for this question. And first, my compliments to Dr. Giesinger for her excellent presentation. Unfortunately, I don't have the answer in the monitor that we can use for a real accurate and precise hemodynamic monitoring. I'm very sorry for that. There are a lot of different modalities available, but I think also a lot of those modalities haven't been validated really in a good, proper way. I can only think of one, and that is the transpulmonary ultrasound dilution method, as the co-status. But it's not a non-invasive monitor. We've got a lot of other technologies, but I'm not sure whether they're precise. And we use them, or they are used a lot also for trend monitoring, but we also have proven in different studies that also trend monitoring is not as good as we expect it to be. So just one monitor that we can use without using the echo, I think that's not available yet. And we're working on that, to be honest. And I think still, if you got a proper monitor non-invasively measuring or estimating the cardiac output or the systemic vascular resistance together with the blood pressure, you will still need the echo, because you want to know how is the actual hemodynamic situation in the baby. Do you have the persistence of shunts? What is the problem? If you got a low cardiac output, you want to be informed about pulmonary vascular resistance, etc. Just to add on, I think, and that's also a question to Dr. Giesinger, would it be possible to also differentiate about what hemodynamic problem there is in the patient based on the characteristics of the arterial blood pressure? You can have a look at systolic blood pressure, diastolic blood pressure, pulse pressure. Don't you think there's a lot of information we can use? And well, let me start with that question, because I think there might be.
I think there is more than people think, and if we look at systolic and diastolic as opposed to mean, we can definitely get more than just mean on its own. Cooling raises your diastolic blood pressure by vasoconstricting in the systemic bed, and low cardiac output is associated with lower systolic blood pressure. And I think those things can help give you a warning sign to look for something else. Unfortunately, they're not very specific, but at least as an indicator to think about looking into things further and thinking about doing echo or other modalities, I think that would be, that's certainly a step up over mean.
Well, a striking example I've seen in real practice is that we did the rounds, and the doctors taking care of a baby just put on therapeutic hypothermia. They thought, well, there's no hemodynamic problem because the mean blood pressure is 50, but they didn't look at the pulse pressure. It was only 5 millimeters of mercury. So there was a big problem, but they just focused on blood pressure and only on the mean blood pressure. So please expand that also to pulse pressure. Yeah.
Excellent point. Dr. Wyman-Lai, you have as a cardiologist, you have the benefit of timing your HIE. Let me see, I think I just lost everybody on my screen. Hold on one second. There you are. You have the benefit of timing your HIE. What do I mean by that? 7:30, you're going to the OR. You're going to undergo cardiopulmonary bypass. Temperatures are going to drop really low. Perfusion is going to go really low. Do you see this in babies post-bypass, similar to what Regan is describing when they are quite hypothermic, when they have been poorly perfused? You've essentially timed your HIE. Do you see the same thing in that patient population? And if so, what's the natural history in those patients?
Excuse me. First of all, I want to congratulate Regan on not just a great talk, but really opening up this area of investigation. I think this is tremendous to note something and that just follow it through with just really good prospective studies, and to the group for emphasizing the importance of looking at outcomes and not just using random surrogate outcomes for determining how to treat patients. As far as timing, I don't think we caused any HIE. So I'm not sure.
Let me be more clear. Let me be more specific. Good point. Let me be more specific. Cooling and its effects on myocardial performance.
Yes,
when these kids are coming off pump and they're really cold,
all sorts of variables there. You know, because we not only cool patients, but we do use, when we stop the heart, often we are giving myocardial protectant. So the only other, I guess we do know that when we cross clamp and do coarctation repairs off bypass and cool the heads, that we can get away with 30 minutes of ischemia and or hypoperfusion and not damage the brain. So there are just so many factors here that that play into this. And I had asked Regan if she could find that slide, because with hypothermia, you're altering systemic resistance, you're altering peripheral vascular resistance, you're altering cerebral vascular resistance. And then I wanted to point out just that on that right-sided figure, you're seeing that there's probably retrograde flow through the arch. So you are, unless that's the subclavian, but I think that's the arch that she's finding here. And you see that you're not just altering PVR, but you're also altering SVR and cerebral vascular resistance. And then you're probably also altering RV function and LV function. So there are just so many different parameters going on here that I do congratulate those of you who've been looking for outcomes, and then also the appropriate surrogate outcomes that you can use for studies. So to that point, I was wondering, Regan, where do you think this research is going, and what are the roles of animal models? What's going to be the role of animal models to try to determine how best to treat patients?
Yeah, so I think that what the questions that we need to start asking are, do our treatments first modify heart function in a predictable fashion, and what are the most biologically logical treatments, and how do they change the circulation? And then repeat the whole thing and look at whether those things influence on outcomes. But I think in terms of the next steps from a clinical perspective, but I think that that animal models can be very helpful in terms of simulating different ways to cause brain injury in different scenarios and how the role of heart function, what's the role of heart function as compared to the role of the initial injury, because until we can actually simulate separating those things out from each other, which obviously we can't do in humans, we need to use animal models in order to do that. And if anybody has a lab that wants to do that research with me, send me an email. I'm more than happy.
We only have about 5 minutes left, and there's some phenomenal questions on the chat. I've got 100 questions in my mind, and really what I want to do is, like I said, we got the who's who of the panel here. Let me turn it over to our panel. Is there anything you guys heard in the last hour that you either want to question or even amplify and say, I really want to bring attention to that you heard?
If it's okay, I would like to ask a question, because I think I was intrigued by the milrinone during the therapeutic hyperthermia and the occurrence of a systemic hypertension. My question is, do you have data on the systemic blood flow during that systemic hypertension? But maybe we shouldn't worry about the blood pressure as long, because why do we need to circulate blood is to transport oxygen to the end organs and especially to the brain. So is it the problem if you got a low blood pressure, provided that your systemic blood flow is within the normal range? Because I would expect with the milrinone, it will be better than before.
Yeah, so that we don't have a large enough sample size to publish that, but having looked after a lot of these babies, I can tell you the echo phenotype. So, and actually I have a baby in our unit right now that I'm looking after that I'm still trying to compensate for milrinone that she got 2 days ago. And the issue, what ends up happening is the systemic vasodilation is so significant that they get low coronary perfusion pressure, and they actually get myocardial ischemia and severe RV dysfunction associated with the systemic hypotension. So many of these babies, if you don't get on top of them quickly, they'll actually get down to the 20s on 10s for blood pressure, and you have to really escalate very dramatically in order to compensate for them. And a lot of people don't see enough of these patients to be able to separate what is disease progression from what is side effect of medication. And so this gets perceived a lot of times as this is just a bad baby and we need to throw more things on top, and maybe they stop the milrinone, maybe they don't. But the hypotension that you find, if you don't do something about it very quickly, is enough. Even though cardiac output is preserved for a while, it's enough to cause myocardial ischemia and result in exacerbating your problem, which then people jack up systemic vasoconstrictors, which are usually dopamine and epinephrine, and those jack up pulmonary vascular resistance. And then you can't tell chicken or egg where things came from. So it ends up being very complicated.
Well, because I always trying to find out at what pressure, diastolic pressure, is critical for the coronary perfusion. And I'm not sure, because if I make an ECG, I never see myocardial ischemia in these patients. Did you? Okay.
Yeah, I don't think we know, but I think that's a good question.
Because what I recently understood is that the coronary perfusion, it's not linear related to the pressure gradient between the right atrium and the aortic root, but it's also influenced by the myocardial contraction. It's also propelled within the myocardium. So there is also, so it's not solely the pressure gradient between those two areas. There's more to that. So I'm not sure what would be the critical lower blood pressure to be acceptable for myocardial perfusion.
Yeah, you're giving me more ideas for RO1s.
I know we're running out of time, Patrick, and I apologize. Can I ask Wyman, if that's okay? Can you amplify that, Wyman? The difference between right coronary and left coronary perfusion. I'm sorry, Patrick, I hope that's okay.
I think that Regan has a very nice discussion on that in terms of the impact of pressures and impact of RV pressure, increased RV pressure, and diminishing the gradient between the aorta and the RV in terms of myocardial perfusion. You know, I would make one comment is we don't see a lot of patients with right-sided heart failure later in life. So I would say, to me, there's a decent chance that the right ventricle is a problem, but only a temporary one. And the focus, as many of the panelists and Regan said, it should be on cerebral flow, and these right ventricles will recover. So toward that, you know, there is some talk about looking just at SD ratios, Regan. I was just wondering if you peeked at that and whether or not that was confirmed in your data set.
I haven't looked at it, but I have a lot of data, so I could go back and look.
Right.
Amir, can I just ask, I want to ask one question, because I think it's a really, and I apologize to people we're going over, but this is a discussion that's not really happened anywhere very much. And I don't think people will mind going a few minutes over, but one comment just to add to what Willem said, which I think is very important, that we need to think beyond perfusion pressure. Your heart rate, your time intervals of perfusion are also very important, in addition to the compliance of the ventricle. But my question is for Pia, because her data is going to be really, really interesting. The effect of sildenafil on the brain, teasing out a direct brain effect versus now what we've talked about in the RV. Is that something that you're going to try to capture in that study? Because I think that particularly will be very interesting, because sildenafil obviously is going to modify kind of RV and pulmonary hemodynamics.
Yes, I think we are, because we have the NIRS, we have the echo, but most importantly, we have the MRI. I'm a brain person. And so we are following this brain and understanding how it may repair the brain. In the animal model, we find it decreases the size of the brain. In fact, it has an effect that is separate from the vasodilatation for which we use, because it decreases the size of the infarct by decreasing the neuroinflammation, preventing apoptosis, increasing neurons. So many other effects than just the vasodilatation, and that's why it's useful in this population. But because one of the side effects is hypotension, you know, that's why we are being careful by putting it. If I can add just one thing, I see one question in the chat is, should we discontinue therapeutic hypothermia if we get refractory hypotension? For now, and because I'm a brain person, I would recommend not to discontinue the therapeutic hypothermia, because that's the only tool that you have to try to prevent the brain injury. Obviously, you need to treat the refractory hypotension, and as Regan say, you should do it sooner than later, because once you're really low, it's really hard to bring back. But then you have other, you know, you have to think of all your solution, but will really stop the therapeutic hypothermia only if, you know, there is no other choice for this patient. That's it.
Can I comment on that? Because I think it's important. We see that very occasionally, and we almost never stop. But what we might do is temporarily modify the temperature target just slightly. And that sometimes is all you need to actually get some temporary stability. So we may just go up by 0.5 degree or 1 degree for a short period of time. Once the patient stabilizes, then go back. So I agree with Pia, we should almost never stop cooling cold turkey.
Since we're going to go over, I have another question, Pia. I'm sorry. We could go on forever on this. We could literally go on forever on this topic.
Yeah.
Pia, I always struggle with this. We know that after HIE, the neonatal brain is very susceptible to oxidative stress. So I always try to find this balance between hypoxia and oxidative stress. And of course, there is no right answer. But as somebody who spends a lot of time in the brain, where do you like to fall in that balance? Is it worse to be slightly hypoxic and slightly hypotensive? Is it worse to be hyperoxic and induce oxidative stress? Do we know which is worse for the neonatal brain after HIE?
I think we don't know. We actually look at our population retrospectively to see if exactly the hypoxia, you know, related to persistent pulmonary hypertension, you know, had an impact. We find that the variation of PaO2 had also an impact on the brain injury. So means, yes, the hypoxia is not good, but the hyperoxia is probably not good. And the big variation that you do between your oxygen, because you're really happy because finally you're oxygenating the patient and you want to keep it there because finally you're succeeding, is probably not good either. But I'm not aware of any trial. It's like the drug inotrope, and yes, we could spend hours because there's always the pro and the cons, and because it's a very particular population of babies because of their brain.
Can I ask one last question, Patrick, or do you want me to close the meeting?
No. I think the audience, I think it's okay because there's some good questions there. And the audience has said, we're very happy. They're enjoying this. So as long as our speakers and panelists kind of, why don't we just say to 2:15, give another 5 minutes and then we can wrap it up if people are not need to save lives or do something important.
So my question actually is for Dr. Lai. You did kind of mention it briefly. Should we follow up those patients as outpatients with cardiology? So we're talking about the brain, and obviously it's very important, but do we know if these patients normalize their function and have no other issues? Do we have that data? Like, do they grow up to have like just normal hearts, or should we, because I mean, they have a main event, right? Like a main hypoxic event that obviously has a huge impact on their heart, just like Regan just showed. So what should we do about those patients kind of like growing up with their hearts?
That's an excellent question. I see a fair number of patients, but by the time they come to me later in life, they're identified as developmental delay, and they have trachs, and they have G-tubes, and they have all sorts of things that complicate the attribution of their RV or LV dysfunction to the initial hypoxic event. So I think absolutely they should be followed. That's worthy of investigation. When we talked about outcomes, obviously the long-term outcome is the one that we care about the most. So I would encourage this group, to be identified, just like we follow hypoplastic left heart syndromes. And now we've switched over from survival and ventricular function to neurological outcomes as adults. And that's something that I think this group is thinking of also. Really, your major outcome is sort of what are they doing as adults? And is it neurologically affecting them? And is their cardiac function, are they dying early, like cancer patients, of radiation, and chemotoxicity? So I don't know the answer to that. I don't know that study has been done, but perhaps other folks on this call have.
I fully agree, Wyman. Our preterm population is telling us that these are vulnerable patients and they have hearts that are abnormal when they leave the NICU. And I think this is no different. I think we have a moral obligation to develop ways to monitor and follow these children.
Right. I do have one question since I'm speaking. Amir and I were looking for the perfect tool to measure systemic perfusion. Could somebody tell me what that is?
Willem got a PhD on this. Willem got a PhD on this topic. What do you think, Willem?
Oh, wow, that's the most difficult question. I'm afraid there is no the golden standard, best monitor, best parameter, but I'm now trying to collaborate with the engineers from the technical universities, whether we could add a sensor, flow sensor, pressure sensor to our umbilical lines or intravascular lines. I think that would possibly be the best reference method. But currently, I'm not aware of the best monitor. We have to do it with all different information from different sources with different accuracy and precision, and that makes it very complex. I'm sorry.
All right, I was given the difficult task to end this discussion. I think we could go on and on with this very passionate panel, and it's been certainly very interesting. I think from the comments that I see, everyone has really enjoyed the talk from Dr. Giesinger and the discussion that followed. So thank you very much, everyone, for joining. And to our speaker and panelists, thank you once again. I think this has been a very, very great afternoon talking about hemodynamics. And please join us at the next meeting for more discussion.
Thank you all.
Thanks, everyone.
Thank you, everybody.
If the group can just stay on a couple of minutes, we can just debrief.